TMD is a very interesting area. We see quite a lot of patients that have TMD symptoms. They often have similar symptoms but widely different causes. So that, again, the first thing that we need to know about the patient is about them, because TMD has such a huge neuromuscular input. It's not about teeth, it's about control of the muscles of the head and neck and face. And so our main aim with the first appointment is to get some information of where we think their problem's coming from, then try and learn about them, so the stresses and high concentration things in their life, because they're the two main areas that cause people to get TMD, certainly from our patients' point of view. And then we give them a lot of information about I give them a lot of information about how I think life in general is adding to this problem, and give them some homework to go home and see if they really have that sort of a problem. You know, what is affecting them is one of the most common things here that I say to particularly the people that work down at the finance end of town, is that you'll be sitting in a meeting and some jumped up little upstart will be getting up talking, waxing on lyrically about something they know nothing about and you know everything about, and yet everybody's listening to them and all you're doing is sitting there clenching and grinding your teeth. And most of those people look at me and say, how well do you know my life? It happens every day. And it's those sort of things, those life things, that really influence TMD. So once we've got over that, and then we make an assessment, we give them a choice about whether they really want to have an occlusal splint or not, because some people hate them, some people love them, but an occlusal splint is really a training aid to help them learn, or help their brain to learn not to touch teeth together. Because teeth naturally should only touch when you chew and when you swallow. And the rest of the time, and in fact when you chew and swallow, the teeth touch, and then the brain tells them the muscles to release and the teeth come apart. When you grind or anterior parafunction while you're concentrating on something, the teeth touch and then the muscles just load up and load up and load up. And so you'll put forces that are 2.5 times greater than what you would normally consciously do when you're chewing hard on a bit of tough steak, which you should never buy, and you won't notice the pain. And at the same time, your jaw might be in an odd position where it's then causing damage to the jaw joints, or also creating big issues with the muscles of the head, neck and face. So the other thing I point out to them is that they should treat their head as something like a bowling ball on a broomstick held in balance by springs. And if you tighten springs up on one side, then they tighten up on the other side. So it's no surprise for those patients to have symptoms in the neck or the back, down the arms, those sorts of things. So TMD is something that you have to have a very open mind about, where the pain is, what muscles are involved, and just what sort of an approach you're going to have to treat it. One of the things that we do pretty much insist on, particularly if there's a clicky jaw joint, is a cone beam CT scan, so that we can get an idea of the position of the condyle, the top part of the jawbone in the fossa, and that gives us a hint about what other damage there might be. And then we might consider also a MRI image or series of images to see what actual damage has happened to the soft tissues, the disc and the ligaments and the muscles. So it's a fairly broad approach, looking at things from a big variety of directions, and that's because TMD has an awfully big variety of causes.